The previous video taught us the importance of calculating an ideal body weight. Calculating an accurate, ideal body weight for each patient is a critical early action in optimizing mechanical ventilation. It is the basis for determining the volume of gas we deliver with each breath to avoid giving too much or too little volume. This can lead to inadequate ventilation or overdistension of the lungs, underscoring your crucial and valued role in patient care. Yes, the T1 is an exceptionally intelligent ventilator, but it only knows your patient's ideal body weight with your input. How do we do the ideal body weight calculation? The T1 interface method to calculate an ideal body weight is straightforward and user-friendly. It doesn't require memorizing a tricky formula or using a calculator. In addition to the T1, you need a tape measure and the height and gender of your patient. This simplicity and ease of use make the process efficient and empower you to deliver breaths confidently with a mechanical ventilator. This learning module's objectives include lessons related to tidal volume, minute ventilation, also called minute volume, frequency, and ventilation dead space. Exploring the breath cycle, inspiratory time, and inspiratory to expiratory ratio are closely linked to ventilation frequency and tidal volume. I will cover those related topics in detail in a subsequent module. You must know some basic equations to follow along with the lesson and use ventilators safely. We measure tidal volume in milliliters and minute ventilation in liters. It is safe to presume you can calculate the ideal body weight using the T1 interface by inputting the patient's height and gender. Tidal volume equals ideal body weight times the volume of gas per kilogram for each breath. The Hamilton automatically calculates the tidal volume by multiplying the ideal body weight by the default median volume of 6 milliliters per kilogram. If a male patient's ideal body weight is 60 kilograms, the ventilator will initiate ventilation with a tidal volume of 360 milliliters. Minute ventilation, often called minute volume, equals tidal volume times frequency or breaths per minute. The average minute ventilation range is between 5 and 8 liters per minute. What is the minute ventilation if the patient has a set tidal volume of 500 milliliters and a frequency of 10 breaths per minute? With a tidal volume of 500 milliliters and a ventilation frequency of 10 breaths, the minute ventilation equals 5 liters. A good rule is that the volume of gas that goes in should equal the volume of gas that exits. When we cover monitoring and waveforms, I will show you how to analyze the expired minute volume and waveforms to determine whether there's an equal volume of gas in and out or unwanted air trapping is present. Exhalation is a passive process and it requires adequate time to complete. It is important to understand that tidal volume and frequency have an inverse relationship in mechanical ventilation. Remember, volume in equals the volume out. The vertical axis of this graphic depicts the frequency, and the horizontal axis represents volume. As the tidal volume increases, the ventilation frequency decreases, allowing time for all that gas to exit the chest and maintain satisfactory minute ventilation. Conversely, as the tidal volume decreases, the ventilation frequency increases to compensate for and maintain adequate minute ventilation. This inverse relationship is critical in mechanical ventilation as it allows for adjustments to tidal volume and ventilation frequency for individual patients based on lung pathology, clinical conditions, metabolic demand, oxygen requirements, and physiological factors. Let's take a closer look. Here we have our male patient, 50 kilograms ideal body weight. To maintain gas exchange, we must provide minute ventilation between 5 and 8 liters, a metric entrenched in ventilation principles. At 4 milliliters per kilogram, the patient requires a frequency of 24 breaths a minute to even approach a minute volume of 5 liters. Low volume means we must increase the frequency. For volumes in the 6 to 7 milliliter median range, the frequency more closely approaches what most would consider an average breath rate. As we move to the higher volumes in the 8 to 10 milliliter per kilogram range, the frequency decreases to 10 breaths per minute to maintain an appropriate minute volume and allow adequate time for exhalation during the breath cycle. By definition, the breath cycle starts at the beginning of inspiration and continues until the end of expiration. There will be more on that topic in the next module. By default, the T1 calculates tidal volume using the median volume of 6 milliliters per kilogram. Patients require mechanical ventilation, but with varying strategies based on their illness, injury, and physiological condition. Therefore, ventilation frequency, tidal volume, and other factors are individualized to the patient. As a side note, in adaptive support ventilation, the T1 leverages the power of the AI integrated ventilation mode. The ventilator determines the ideal combination of frequency, tidal volume, inspiratory to expiratory ratio, inspiratory time, and other parameters to ensure safe and comfortable mechanical ventilation for the patient. The volume per kilogram can range between 4 milliliters per kilogram to 9 or even 10 milliliters per kilogram. Patients in the 6 to 7 milliliter per kilogram range may be on a mechanical ventilator for airway protection, heart failure, early ARDS, or could have issues with poor lung compliance. At the higher end of the scale, in the 8 to 10 milliliter per kilogram range, patients with highly compliant lungs and obstructive pathology, such as COPD, may benefit from larger volumes and a lower frequency to allow a longer interval for exhalation. Trauma patients may benefit from a higher tidal volume and lower respiratory rate to reduce atelectasis from pain, immobility, and shallow breathing. Trauma patients may also suffer a significant loss of blood volume, which leads to decreased oxygen delivery to the tissues and reduced blood volume to the alveoli. In this example of ventilation perfusion mismatch, the larger tidal volumes can help improve oxygenation by increasing the amount of oxygen delivered to the lungs with each breath. In patients receiving volumes in the 4 to 5 milliliters per kilogram range, we minimize the risk of ventilator-induced lung trauma, but jeopardize rebreathing carbon dioxide and underinflating the alveoli because of dead space ventilation. Dead space ventilation is the volume of air per minute that does not participate in gas exchange. Anatomical dead space is located in the upper airways, while alveolar dead space is the volume of air in contact with non-perfused alveoli. Equipment dead space includes the ventilator circuit, endotracheal tube, and any supplies leading to the airway that does not participate in gas exchange. Physiological dead space is the total of all the dead space. Depending on who you ask, dead space volume equals about 100 to 150 milliliters of gas that does not interact with the alveoli with each breath. Let's look more closely at the patient receiving a tidal volume calculated at 4 milliliters per kilogram with a frequency of 24 breaths a minute to illustrate the potential impact of dead space ventilation. If we limit the tidal volume to only 200 milliliters per breath to accommodate a frequency of 24, we end up with a minute ventilation of 4,800 milliliters or 4.8 liters a minute. That sounds all right, especially if we're worried about limiting volume like in an ARDS patient. Now, let's subtract the dead space volume from the 4,800 milliliters to see what volume of gas the alveoli receive. Remember, the volume of gas hanging in the dead space does not participate in gas exchange. Using 100 mLs of dead space for each breath cuts our volume per breath and our minute ventilation in half. That is not good. If we calculate dead space at 150 milliliters for each breath, we provide only 50 milliliters of volume because 150 milliliters of 200 milliliters only participates in the dead space ventilation. An adult patient with a minute ventilation of 1.2 to 2.4 liters is inadequate. Since 1/2 or more of the intended volume is in the circuit, ET tube, and upper airways, it does not participate in gas exchange. The patient is likely inadequately oxygenated and rebreathing their carbon dioxide too.